Okay, we are in the fourth and final part of birth procedures and medical management of labor. Should be relatively quick. There are two things we really talk about here, and that's active management of third stage of labor and the perineal repair. Um, so let's talk about what active management of third stage. So you may hear me refer periodically to active management of conditions and expectant management. Expectant management is what we used to do most of the time. And that's allowing a natural process to take its course. And that's one way to do it. We would wait and wait and wait for that placenta, the delivery of the baby would come. We'd get other stuff done, and we'd just kind of sit there and wait some more. And eventually, we'd get that gush of blood. The cord would look longer. The uterus would like contract firmly and look very globular or round. And we'd know we were getting ready to have the placenta. And we would kind of maybe guide it out, but not, or the provider would guide it out, but we didn't really do much to make it happen any faster. Well, the evidence is now suggesting that we get less blood loss if we actively manage the third stage of labor. So the purpose of it is to prevent a postpartum hemorrhage or to really minimize blood loss to the patient. There are two methods or two things that are done in the active management of third stage. If they don't work, there are a few other things that can be done. They're mostly like nipple stimulation and bonding skin to skin, which we should be doing anyway. But oxytocin, so that bag of pit, if you're using it for induction, you're now going to change the rate. Now we're not doing milli-units, we're doing whole units. So multiply by, 1,000 or whatever. You're going to do a bolus as soon as the infant is delivered. And that's going to help the uterus contract. That's going to help the placenta detach, and it's going to help the body push that placenta out. We used to kind of open it up as free flow after the placenta came out to prevent bleeding. Now what's done is we run it at, in my place, because we have that 1-to-1 ratio, that 30 units in 500 mLs. We run it at 334, which gives 10 units over half an hour. Now, if you don't have an IV running, you can give IM Pitocin at this point. It just doesn't, it's not as quick as IV, but you would give 10 units IM. So you give oxytocin, and that's one way to actively manage the third stage. And then the next thing that the provider will do is pull on the cord very gently, the gentle downward traction. And the whole idea of gentle is that you don't want to snap off the cord. So it has to be like a steady, easy does it kind of thing. Because if you snap off the cord, you're going to get bleeding. They'll usually wait for those signs the placenta is separating, and during a contraction, they'll tell mom, okay, push, no bones for this baby. But they're sort of pulling on the cord. They're not just waiting for mom to deliver the placenta. And it really does seem to minimize that blood loss. Okay, and then we're going to go on. This is our last topic for today, and it's pretty brief. This is the repair of whatever is open. So if it got cut or if it tore, you got to put it back together, or at least the provider does, and you're going to help. So it involves suturing, tears, or closing the incision. And I say or closing the incision because in episiotomy, really think of it as like a mini surgical procedure. There are first degree tears if we're dealing with lacerations, and that's just skin and mucosa. And some of them, if they're small, we might even call them skid marks. They tend to heal on their own, but a lot of them will need repair. And then we have second degree lacerations, the skin, vaginal mucosa, and now we have the fascia of the perineal body. And so at this point, definitely a repair is needed. Third degree goes a little bit deeper. Now we're going into the muscle, and a lot of times the third degree will go towards the rectum, and that's not good. Remember that an episiotomy is automatically a third degree. It was preferred by OBs for a long time because if they knew where they cut, they knew where to sew. But it usually goes deeper and longer than a natural laceration does. But this is a little more complicated of a repair, and it will take a little bit longer. It will also take mom a lot longer to feel better, even through her postpartum course, and maybe a couple months after. She may still have some degree of discomfort, particularly during intimacy. Fourth degree lacerations, these are the worst. They are the worst of the worst. They involve the skin, the mucous membranes, the muscle, and the rectal sphincter. It goes all the way through to the rectal. You end up with one big cavity. It's just awful. The instruments even that they use to repair these look like medieval torture instruments. But basically, you need a skilled OB provider. OB, by the way, is a surgical specialty, so these guys are usually pretty good at it. But you want to make sure that you have a skilled person doing this repair, because if not, they could have anal incontinence, they could have other problems. But that's going to be a really, really tricky repair. The nurse's responsibilities: you're going to manage supplies just like you do in the OR, get the non-sterile packaging off and empty it onto the sterile field. You might have to help the doctor get the local anesthetic into the needle. Sometimes you just use the epidural if that's what's running. And then you're going to perform counts for anything that goes in the vagina. You have to make sure it came out. All your sharps should be accounted for, the needle for the lidocaine, the sutures, and any sponges should be accounted for. You're also going to provide encouragement and support. That kind of goes without saying. And I didn't put it on the slide, but you're going to make sure that there's a good source of light, and make sure that the light is aiming where the provider needs to see. For the 4th degree, you're probably going to have to go get a speculum as well. And I think, that is the last slide. So we made it all through Module 3, Class 2. See you in class on Thursday.